question for Lourdes. The difference between us in neurocritical care and, let's say, I don't know, general surgery is that our patients cannot, most of the time, express their wishes. So you have to rely on surrogate decision makers. So it's not the same thing that you have somebody who's awake and you are talking to him about amputating his leg, for example, and then he can tell you what to expect. So as you know very well, the percentage of patients who are admitted in ICUs with known wishes is less than 2/3. There are some studies that go up to 83% of them do not have written or expressed wishes. So you have to rely again on surrogate decision makers. You are 1 hour away from the most powerful city in the world, okay, south of you. Why don't you, for example, advocate, this great institution advocate, the same way that we have advocate for organ donation. So you go to the DMV to, for example, to renew your license or get your license. They ask you the question, if you want to become a donor, why don't you advocate, for example, every patient, every person in the United States, every citizen of the United States to have some kind of express wishes, very general, not necessarily, if that happens to me and I have blue eyes and I have a stroke and it's on the left, very general idea about what would be the wishes to help families, help hospitals, help intensivists, help cost care reduction.
I think you just hit on the problem. Express wishes for our patients typically do not apply. When we look at advanced directives, they're typically in the setting of life-limiting illness. And I mean, as you saw in the trajectories of illness, the problem with our patient population is that most of them do not progress to death. We cannot really say that this is life-limiting. So how do you really express wishes when you don't really know what that disability is going to look like and how people are going to adapt and cope and sort of recalibrate their expectations to living with new disability? I think that is a challenge. I don't have the answer, unfortunately, but I think that we have a real problem within our current setting in utilizing advanced directives to direct decision-making. Because in most situations, that judgment does not apply. And we haven't really thought about what, the disability paradox, right? What disability looks like and what it means to people and how they can, sort of recalibrate their internal expectations of what it's going to be like to live with that disability. So I don't have the answer, unfortunately. I think the best thing that we can do is to prepare decision makers to realize that this is an occurrence. It's a phenomenon that we see in this patient population, and knowing that, how can we help them make the best possible decisions for their loved one?
John, what's the range of compounds that you could make in this portable synthetic crate?
Thanks, Dan, for the question. So the range of compounds that we've synthesized so far spans a gamut of a variety of small molecules, the one that I showed you. So, like I said, we've synthesized about 25 different active ingredients, all diverse sets of compounds. Now, in addition to that, we've developed data intelligence tools and chemical mapping capabilities that have essentially analyzed lots of the chemistry space to determine different synthetic routes to arrive at different molecules as a means to secure the supply chain. And when we look at those different synthetic transformations and have applied that to our platform capability, we can synthesize roughly, I think it's about 750 different small molecules on our platform. Now, we haven't synthesized all 750, we've demonstrated 25. But in terms of the chemical reaction space we can access on the platform, it corresponds to about 750 different molecules. We also have some technology and intellectual property around miniaturized, briefcase-sized production of large molecules and biologics. But it's, again, that's a little bit more in its infancy, but I also see that being a component of the future as well.
And how does that match up to what we consume in a regular hospital on a daily basis in terms of number of compounds?
It actually matches up to a vast majority of the things that we typically consume, because again, the vast number of medicines that we're consuming here on a typical formulary are going to be our small molecule and generic medicines. So it's probably 80%, if I had to guess, of a typical hospital formulary of what we need day to day just to run our operation here.
Sujatha, it's fantastic presentation and really exciting work. The question is, you dealt with delivery. What about dosing and off-target effects? How do you think about that? I mean, the pathways that you're modulating, you go too far in one direction, that could be just as devastating as if you go too far in the wrong direction.
Yeah, that's a great question. I think there are a couple of things that modulate it by themselves. One is what we are finding, especially for microglia and macrophages, is that the phagocytosis capability goes down so they take less of the drug in. You can suppress it quite a bit, but again, the exciting part is the normal glial cells continue their function. They do not pick it up at all. So so that will continue. It's only the ones that are abnormal, that are dysregulated, that are picking it up. And the amount that goes up, that it picks up also varies. So that the disease almost self-regulates itself. Yeah, and off target. So the drug does not release, you can tailor it in a way that it just won't release anywhere else. So it doesn't, if it's not picked up, the circulation time is really short. So when you think about, typically when we think about delivering to the CNS, we want something that has a long circulation time because we want the concentration in the brain to be. This has a very short circulation time. So it's pretty much the exact opposite of conventional wisdom that works here. So it has a very short circulation time. So if it's not picked up by the cells, it's out. It's actually in the urine. If we've done a mass balance, it's excreted intact. And so only what's in the cell gets released in those cells, and the action is just there.
Hi, hello. So I have a comment and a question directed primarily at Lourdes, but I think important also for Sujatha and John. One of the things that Dan Hanley taught me when I was a fellow, standing at the bed of the patient dying, Dan taught me that, Romer, if we say this is futile, it becomes futile. And that has reverberated in me. That's why I ended up in cardiac arrest, which is a futile illness, post-resuscitation. Now, my question is, the biggest problem we have right now is our prognostic tools. 80 to 99% of them are flawed. Whether we're talking about ICH, we're talking about cardiac arrest, we're talking about whatever entity. And neurocritical care is one of those areas that have fought against this nihilism and tried to design a lot of these things. But I think what we really need moving forward is it's good to create a framework of talking to families, it's good to create a framework of research, how to do this, it's good to create a framework of drug delivery. But the problem is if we do not understand the natural history, because all of this is aborted because of self-fulfilling prophecy, then everything that we're doing will all fall apart. And we're seeing that over and over again with negative randomized trials over and over again, not only in neurocritical care, but in critical care in general. So my question to ourselves is, how do we move forward in finding a dynamic, responsive, and accurate prognosticators early on as we decide whether we're developing clinical interventions, developing drugs, or developing how we talk with families, because our tools are really no good for prognosis.
Absolutely. I agree with that. I think the first step is acknowledging the fact that we have a problem with the way that we prognosticate. That's the first step. The second thing is that I think that it is very flawed to prognosticate so early on with our patients. So one of the reasons why we have such a problem with prognostication is because of that. Number one, we use it very early, right, in their disease course, where we don't really have an opportunity to see what the long-term recovery is going to look like. And the second is the fact that we invoke withdrawal of life-sustaining treatment. And that's what, the primary reason why most of our prognostic tools are flawed, because they encompass these patient populations that have had withdrawal. So I think, one of the ways that we can perhaps rectify this is, as I suggested, is perhaps we need to look at long-term recovery clinics. For those patients that have made the decision, surrogates have made the decision, I'm going to pursue everything. I'm going to pursue aggressive treatment. Perhaps we need to follow those survivors very, very closely. Look at their health-related quality of life, look at their long-term recovery trajectories, and use that data to help us make better estimates and that we can provide to patients and to families moving forward.
I think that's a great point, Romero. It's just, I think the critical thing is pragmatic clinical trial design. I think it's very important to think about what we always have to start, I believe, with a narrowed population where you understand the pathophysiology and you know what you're going after. And then try to extrapolate. Why is it that all of these Alzheimer's trials fail, or cardiac arrest? It's a massive, or TBI, it's especially. It's just a huge, very heterogeneous population. So unless we have a way to narrow down or identify a subgroup in that to start with, because again, I think we have to be, if we think about something that is precision, we have to think about what is exactly happening over there. What is the pathophysiology that we're going after? And it's not the same for everybody. So I think that's really, we have to start thinking about the populations not as one big loop, but just smaller subgroups of populations that we have to treat with different things.
I have a question for Lourdes, and my question is, how do we get palliative involved from the jump, so that, one is that it doesn't feel like this is the end of it, because I feel like that's one of the areas where the patients, the families could benefit more, especially given the slim staffing that we have right now, social work and all that, and the little gaps that we have in the services that we could provide. So how do we get palliative involved to kind of help us pick up and fill some of those gaps in terms of like being available for the families? Because a lot of times, the providers can't and we can't.
Absolutely. I think first and foremost, I think that we need to upskill ourselves in providing primary palliative care to our patients and to our families. And there are mechanisms for us to be able to do that, things like Vital Talk, where we can actually receive formalized training. I've always thought about the fact that, we are trained in being able to deliver these life-saving interventions, but we don't have formalized training in how to talk to patients and families. And that's a really critical area that I think can be easily rectified. Palliative care, they don't have all the resources, right, to be throughout the entire hospital. While we all wish for them to be fully integrated within our unit, there are resource limitations to that. So I think one of the things is making sure that we provide adequate, effective primary palliative care to our patients and our families with the additional training and tools that we need in order to do that. I think the other thing is that we have several misconceptions about what palliative care is. We've all sort of jokingly said that perhaps they need to have a rebranding, right, of the name. I think making sure that we tackle those misconceptions and know that it is not end-of-life care, it is quality of life-oriented care. I think tackling that is first and foremost. And the second is understanding that we all provide primary palliation to our patients and families. It is not just provided by a consultant service or specialist level teams.
Thank you. I have a comment and then a question.
Lourdes, thank you for focusing your career on this, because I think it's been a long time coming, and we've waited a lot to have energetic people like you who want to devote their careers to this topic. And also thanks to people like Dan Hanley, who have opened up the scope of our thoughts with regard to recovery, and for creating very robust clinical trials that no longer focus just on primary endpoints of death and severe disability, but are looking at very robust secondary outcomes, which will allow us to learn about how do we define futility in the future. I say that because still today, one of the most difficult things we do is help families at this time. And I can remember many conversations where we were delivering what we thought was the best advice to surrogates and to patients. And thankfully, we'll hopefully someday have better data to guide them. So thank you both for that. My question is to Sujatha, because it seems to me also that focusing on just inflammation for a moment here, there's always a question of what's good inflammation and what's bad inflammation, right? So autoimmune diseases where normal cells are attacked by the immune system, that's a no-brainer. But in damaged tissue models, some of that inflammation is probably good. It clears debris, it allows other cells around to function in a normal way. So it appears that that your delivery system, just focusing on inflammation, may help us determine how much inflammation is good versus bad inflammation. Because I still believe that there is some good towards some good outcome for the inflammatory response in certain diseases. So it's an interesting thing to think about, I think, as well.
Yeah, no, absolutely, yeah. And I think again, I think it would vary based on what we are going after. For example, in COVID, we knew in severe COVID, it's just a disaster. It's just too much inflammation. But wound healing, inflammation is important because that is necessary for healing it. But, and that's where what we are going after is modulation. And then that's where the target can also change. What type of, what you want to deliver would kind of be based on what you're trying to do over there. And as far as wide, and this is a great point, because in hypoxic ischemic encephalopathy in neonates, it wasn't very clear if the inflammation is good or bad over there. The neuroinflammatory conditions, it's straightforward, but infection related is straightforward. But in this, it was not very clear. But interestingly, what we found was happening is that the glia was just getting modulated to do what they normally do. So we're not killing the glial cells. We're not completely changing it. We're not putting it in the other spectrum where it can start behaving like a tumor-associated macrophage and start proliferating like crazy. It just switches back to what its normal function is. And that's where it helps. So, and I think it just helps the brain recover on its own. So there's always a bit of, that's why we are also seeing a bit of in our models, we see a bit of a lag. It takes time, but then the catch-up happens.
Hi, great panel. I enjoyed it. Lourdes, I wanted to just ask you a question. I'm a big fan of your work and what you've done with the data that we have generated together. The issue of tracking outcome, not to say predicting outcome, you've got odds ratio, then you've got variances and uncertainties. But also for an individual, sitting at point A in time. I'm not sure what that means, to be 2.5 likely with that much variance that I will make a great recovery versus that I won't. So, a lot of the patients and families are reaching out for straws. They will take the 1 in a million, and then, they have to understand that if that doesn't work out, are they able to live with the alternative? And it's in that way that people make decisions, because 2/3 being okay by certain standard after a year, what about the other third? You know, you know, if we tell everybody, you know, you should do it this way because 2/3 do that, what does that mean? So I think the idea of telling ahead of time what you want is so weak because we don't really know what we want. We don't really know what it looks like. So how do we go about advising people? We all want to make informed decision, but it's tough. What statistics are applied to this? That's the question.
It is extremely difficult. So what statistics are applied? Well, right now the statistics that we have, we know are flawed, right? So I can start off with that. I don't know what it's going to look like in the future in terms of how we're going to be able to accurately predict outcome on a precise, individualized level. We don't even really understand how people recalibrate their expectations with disability. We don't understand what that paradox looks like. You know, I just pulled the 3 papers that were recently published on this, and those are the only papers that I see in acute neurological injury in terms of describing this disability paradox. I think that one of the problems that we've had is that as observers, we have implemented these functional disability scales that we thought were appropriate as outcome measures, and it turns out that perhaps we were wrong, right? We didn't engage the patients themselves and ask them, what does a meaningful outcome look like? I wish I had all the answers for what it looks like. I think that, you know, we need to start off with, first of all, you know, developing these think tank ideas, right? And bringing people together so that we can design trials with primary endpoints that are meaningful to people. And so that we can look at prognostication perhaps from a different perspective.
And then Panos. Romer, maybe two comments. I think you asked a very good question, which Assam just re-asked, and which Lourdes is trying to find a path forward. That question, I think, starts with, we have to say we don't know the answer. And that's the only way to deal on the patient and family side. But for the specific question you asked, you know, a bunch of trials fail and we tried to rescue them. It's a little bit like a root cause analysis that we do when something doesn't go the way we want it to go in the operating room or in the ICU or in the anesthesia suite. And we look at our mistakes, which is good because all of us have the problem that we're A to B to C people, and it's very hard to admit, I don't know how to link A and D, which is what the families are offering, and some families are asking, and some families are asking us to link A and H or A and K. So this is a hard problem. The thing that we're not, I said I wouldn't talk about trial design, but a way around this situation that sometimes works in precision medicine is what happened in Alzheimer's, where in the Columbia family cohort, where there's autosomal dominant Alzheimer's, and for the last 4 generations, everybody gets Alzheimer's at age 50 and has a severe mental deterioration. Looking for the exceptions, which is what the Harvard group did with that disease, and finding somebody who we use our predictive analytics to say they're not going to do well, and when they do well, finding out what the precise reason is for them doing well, tells us a lot about the factors that are producing the poor outcome. And maybe in what we heard about dendritic nanoparticle drug targeting, the critical factor that is important to changing that process. And in that story, it turned out that this one out of, I think, 2,000 people in the family cohort was a lady who continued to accumulate amyloid on her PET scan, but she didn't develop cognitive dysfunction. And she didn't induce the way everybody else in her family tree induced the protein tau, which looks like it's a critical factor in the progression from amyloid production, not managing amyloid removal, and then developing dementia. So doing a population-based analysis of unexpected survivors is something we're not doing enough of. And there are some examples. The example of when we started the NCCU that Mark Rogers got all excited about, of a 9-year-old boy who fell through the ice in Chicago and was underwater, couldn't breathe for close to 60 minutes, but was apparently cold and frozen enough and had a young enough heart, and I guess better microglia and glia than us old people, who did make a recovery. And, so I think looking for those winners rather than focusing on the losers is another part of how we ought to design our efforts.
Lourdes, and building on what Dan said and before Romer said about the natural history of diseases. We are in 2023. We cannot rely on data from, 1979, the NIH collaborative study for brain death, for example. So we need new data from reliable sources. And there are situations when you can have that. So for example, there are countries in the world when there is no withdrawal of life support, okay? I just came back 3 weeks ago from Dubai and Abu Dhabi. The tower has the name of the Caliph, of course. They don't withdraw life support there. The patients stay in the ICU forever. There is South Korea. They don't withdraw life support. Actually, one of the best prognostic studies that I've read recently was from South Korea in cardiac arrest, how these patients fare. So maybe, and these are advanced countries. They're not MIC countries. They have technology and they use technology. So maybe we can reinvent or relook at the natural history of the diseases and then go back to what Dan was saying, find the exceptions to the rule and build on that. Because in the United States and Europe and in the developed world of this side of the world, yeah, you cannot do that anymore. So.
Thank you for that comment. Absolutely.
I think for the interest of time, I think we're going to pause here. Thank you very much. And so we'll come back at 3:35. There's snacks outside so that we can take a little break and come back. Thank you.